you are joining.
Good morning, everybody. Very warm welcome to our public board meeting. I know a number of us, including me actually, are struggling with internet connections today. So if that ends up being the case, I suggest the person suffering puts their camera off. It's a long way from being ideal, but I think hearing each other is probably the most important thing. So that means if you can't hear me, someone needs to wave at me frantically in order that I know to put my camera off. So we have apologies for absence from James Marsh, but I don't know of any others unless Meg or Barbara is about to tell me something. No? So if we could make a note of that. And declarations of interest. We have the normal what I call twin-hatted declarations, but we're all familiar with those. Aruna, you have a new declaration.
Yes, I've just been appointed as a non-executive director to the Tavistock and Portman NHS Foundation Trust.
Thank you, Aruna. Well, congratulations on your new appointment. I think you will make a big contribution to that board, and it'll be interesting, though it's a very different trust to our own, to see the learning that comes back from that. Any other declarations that I'm not aware of? No, thank you. Minutes of our previous meeting, are those agreed? Is everyone happy with those? I'll take silence as assent. Thank you. That takes me to my update. There were just a few things I wanted to mention. The first two were about visits. We received a visit, I think it was only last week now, from Gillian Keegan, who is a minister in the Health and Social Care Department of Government, and she was with us for the whole morning and was able to see the work that our colleagues in Surrey Downs Health and Care are doing alongside obviously the hospital, so the GPs and the community services which we run. And a big thank you to Thurza and her team, who did us proud. They demonstrated what we know about how well that service works for our patients, and I think the minister left very impressed, which is always good to know. And we had a visit the very next day from the Chief Executive of NHS Providers. He was joined by the new chair designate of the Surrey ICS. And they had a similar kind of presentation. So our poor staff we're doing that for twice that week, but again, Chris and Ian were hugely impressed at the difference we were able to make to patients' lives. I wanted to comment, although I know Jacqueline will say something about some of the great events that happened during Black History Month. There were a number of notable speakers, and I thought it was absolutely fabulous. I wanted to perhaps finish my remarks by talking about our ED department, and indeed the whole hospital. When ED works well, it's because the whole hospital's working well, and our ED, who are under the same enormous pressure that everywhere in the country have been doing the most fantastic job, and they've been right at the top of the league tables. Now that's good, I guess, for staff to know that our performance is so good, but what we need to remember is that it means our patients are getting a prompt and effective care. But when the whole of the NHS is under such pressure, I just thought it was worth worth me remarking upon what an amazing job I think our teams are doing in the most difficult of circumstances. So that's all from me. I'm going to pass over to Jacqueline and hope that I haven't stolen too much of her thunder. Jacqueline.
Not too much of that, thank you, Chairman. Thank you very much, and I take the paper as read. I'm not going to go through each one, you'll be glad to know. I think just to give an overview about, despite how busy our hospitals are, some of the great work that teams have been doing, whether it has been celebrating Black History Month, where we had, as Gillian says, notable speakers, including Levi Roots, who brought his restaurant to St Helier, as well as lots of other great events going on, and also that we also appointed our first woman and BME General Surgeon, which is a thrill to me, being a big supporter of women in healthcare. I think trying to engage and with our staff around some of the things that we really need to support them with. So Glam Up for Winter is a campaign that we've launched, which is about get vaccinated, do your lateral flow test, make sure that you are appraising or have been appraised, ensure that you've got your mandatory training up to date, and look after yourself, mental health and well-being. And that's beginning to take a little bit of grip in the organisation, and I'm really pleased to see that. I think just the other thing I wanted to particularly mention was flu jabs and COVID boosters. You will have seen this week that their letter has come out to all chief execs around the fact that we should expect all frontline staff to be fully vaccinated by the end of this financial year. And I think all of the exec would much rather that we enabled our staff to want to be vaccinated, because they understand and have the data about why it's important. And I'm daily reminded about the patients we have in our ITUs in our hospitals that haven't been vaccinated and are the worse for that. And with that as well, COVID alongside flu will be quite a lethal combination. So not only ensuring that our staff have access to flu vaccines, which I know we've set up roving pop-up clinics, etc., but also that we encourage our local public. And with that as well, the introducing our people's panel, which I'm delighted to see, about how we co-design with our patients and our local populations, not only what buildings look like, but how care is given and the pathways of care. With that, Gillian, there's only one more thing I wanted to mention, which isn't on here because it only happened 2 days ago, is I was delighted to sign the Armed Forces Covenant on behalf of Epsom St Helier Hospital with the MOD this week. It happened just the day before Armistice, but not only that, it was also great to see the amount of poppies, one of which I'm wearing, which is knitted by 400 of them by some of our local people that we not only decorate our shoulders with, but also decorated our hospital with, and it was our hospitals with. It was such a moving event signing the covenant, and so brilliant to see the poppies in and around our two sites. So thank you so much, Gillian. I wasn't going to mention any more, but of course I'm happy to take any further questions.
Thank you, Jacqueline. Any questions for Jacqueline on the basis of what Peter?
Thank you very much for that, Jacqueline. Some really positive developments there. I'm just picking up the vaccine mandation, but more from the impact on social care deadline, which is already just passed. And do you anticipate any kind of knock-on effects from the social care mandation on our trust? Thank you.
So there already is some knock-on effects from that. So we know that in announcing a mandatory vaccinations, that actually there was a 10% increase in uptake, but we are also expecting to see, I think it's been 5 to 10% reduction in social care staff. And yes, it is already impacting on us being able to discharge some of our patients who need ongoing care into the community. I'm sure Philippa might pick that up when she talks about that. That's why I go back to, there is no clarity at the moment. I understand that it will come out in later documentation about what happens if our frontline staff refuse. because we cannot accommodate all our staff into other roles that aren't frontline in that case, because that will be the question our staff will ask us, I know. But that's why I would much rather have the local evidence, which is what we've got and what I know Arlene is beginning to use about what actually it means by not having the vaccine. So we keep going, Peter, we keep going. Thank you.
Thank you very much.
And Jacqueline, it follows from that the executive will be bringing back to board a report about the implications of the deadline of the 31st of March next year.
Yes, and I think we need a little bit more information, Gillian, because I mean, Arlene's obviously got more understanding, has had more, gone through the letter in a lot more detail, because there are lots of links in the letter that I didn't open all the links. But I think we need to just make sure that we fully understand all the consequences of not doing that, as much as what that means that we might need to do more in order for that to happen. So I think, yes, we will do. We just need to make sure it's at the time we've got all the appropriate information.
Thank you. Yes, I realised the letter's just arrived, and like you, I saw all the links and read the letter and didn't have time to read all the links. And I know the process of reading those links and absorbing it and thinking about our own planning will be underway. So thank you for that. I can't see any other hands. So I'm going to move on to item 2.1 on our agenda, which is the infection control update. And Arlene, that's over to you.
You're on mute, Arlene. And you are, Gillian.
Good morning. Thank you.
Thank you.
Thank you, Chair, and good morning, everybody. By way of the infection control update, today I want to talk about the process that we have used, or we are using, for nosocomial infections in the trust. As we know, it is quite important for us to monitor nosocomial infection rates and to ensure that actions are taken from any learning identified. If I just take you through the paper, which I will take as read, up to September 2021, the trust care admitted 123,288 patients to our inpatient hospital beds. Of those, 3,246 tested positive for COVID, and sadly 959 of those patients have died with or of COVID. That does not include the community hospital beds, which we don't include in the numbers, and those are 14 deaths in those, and we have 18 patients who sadly died in ED, and that's, as I say, patients who died with or of COVID. We have been working, as you know, with evolving guidance around how we manage deaths due to COVID, particularly nosocomial deaths, and whether they are declared as patient safety incidents. We as an organization have worked with our Southwest London colleagues, so Kingston, Croydon, George's, to come up with a standardized way of how we address those, particularly the patients who have died with definite hospital-acquired COVID infections. Most of us will know that there are several categories that have been identified in terms of where the patient acquired COVID, and if the patient tests positive within from the day of admission up to 7 days, that is definitely considered to be definitely community acquired. If the patient contracted COVID between day 8 or tested positive for COVID between day 8 and day 14, that is considered to be probable hospital acquired. And any patient who tests positive for the first time after day 15 is considered to have definite hospital acquired COVID-19. And this for this paper, we have looked specifically at describing the process that we use for all nosocomial infections, and that is a prospective process that we have put in since March 2021, where every patient that develops a nosocomial infection, we undertake a root cause analysis and take that through our incident review panel for decision making around whether it is an SI or not, and that has happened for all those patients since March 2021. However, prior to March 2021, when new guidance came into effect, we still would complete a root cause analysis for those patients, but we had not declared them as SIs. And with the new guidance, we have decided across Southwest London that we would declare them and ensure that duty of candor was enacted for all of those patients. We have started with the second wave, and we have across Southwest London assumed the second wave as August 2020 till June 2021. And duty of candor has been enacted for the 60 patients for Epsom and Centellia who developed a definite hospital-acquired COVID-19 infection. Those, the paper describes the process that we've used and the process that we use prospectively. So all of those letters have, well, we're in the process of sending all those letters out. There are still a couple where we don't have accurate next of kin details, and we don't want to send the letter to the wrong person. So we are working on that. We have set up a dedicated phone line so that any relative who gets that letter has the opportunity to contact us to discuss the case or to answer any further questions that they may have. As part of our process, though, the medical examiner, which role for us came in August last year, has already spoken to quite a number of these families anyway. So that has meant that we haven't had many. We have had 5 relatives contact us to say that they either need further information or they would like to discuss the case. And in the majority of those cases, it's really not about COVID anyway. It is about some other aspect of the care. All of the cases are also reviewed. I have a structured judgment review where the care for that patient leading up to their death is also reviewed. So the 60 letters have gone out, and the plan from this week was that we would send out the letters from the first wave, which would be March 2020 to July 2020, and we're in the process of doing that. And for us, that is 22 patients. So, and that is what the paper summarizes. I am happy to take any questions. I suppose the last thing to say actually is of the letters that went out, we have also received 3 complimentary letters thanking us for our honesty and openness in ensuring that the duty of candor process has been undertaken. Thank you, and I will take any questions.
Thank you very much indeed, Arlene. I'm so pleased we're underway with this process now. So questions or comments from colleagues? I can't see any hands at the moment. Chris.
Thank you. Thank you for the report, Arlene. Just on this hotline that people can phone, can you just tell us, I mean, it is easily accessible, is it? It's not sort of ring back between 8:30 and 9 on the 3rd Wednesday of the month or something like that. Could you just tell us a bit more about the hotline? Because I think it does need to be user-friendly for people in these situations. Thank you.
It is a dedicated phone line. Thank you, Chris. It is a dedicated phone line. So that is the only use of that number. And we've been clear in the letter during which times members of the public can access that. And it's initially responded by our patient team, our patient liaison team. So, and they then field the questions and direct the individual to the right person. So it might be if it's a clinician, if it's the ward manager, or if it's infection control. But it is very clear in the letter the days, and it is Monday to Friday currently that is opened.
Thank you very much.
Thank you, Arlene. Are there any other questions? If not, might I ask something, Arlene, which it's kind of follows on from the report, I suppose. Could you just tell me how you audit, or how we audit? I don't mean you personally. How we audit that the tests are being carried out at the 3 day at the intervals that we have to. You know, there are 3 times, I know, and I've not got the number of days absolutely clear in my head, but I think you know what I'm talking about.
Yes.
So that we have confidence that we are keeping on top of that, because I think it's actually harder than people perhaps realise sometimes if we're having to move people around the hospital. So could you just say a little bit about that for me? Thank you.
Thank you. Thanks, Gillian. We have it's an electronic process. So we have our business intelligence team pulls the data from our labs. So it follows the patient as opposed to the ward. So what happens is that the test is done in ED or AMU. That's the first one. That is then recorded, taken to the lab, recorded, and every day we get a report from our business intelligence team about the numbers of patients who had a first test, the number of any patients that are outstanding, their day 3 or their day 5 or their day 7 swab. So we get that as the exec team every morning, and my team in the background will pick any outstanding ones, and we get the entire list as well via a link of all of the patients that haven't had a test for whatever reason. My team then follows it up with the heads of nursing and the ward managers to say, you have this patient, and we know exactly which patient it is that hasn't had a test. So that's the process that we use. And however, you know, this week, as part of our rapid response process, we picked up that there was one ward in particular that have decided, what they've decided to do means that they are slipping more than other wards, and therefore we have asked for that system to be changed. But that's what we do. And the numbers have fallen significantly because, you know, when we first started testing, you know, our day 3 swabs, I think, you know, we had double figures of patients who hadn't had one. And now we have maybe a couple, and some of that is due to patients who are too agitated to be PCR tested if they're confused or whatever. So that's the process.
Thank you very much indeed, Arlene. I'm pleased to hear that it is as thorough as you've described. That hasn't created an opportunity for anybody else, so I'm assuming that means the thoroughness of the report is welcomed, and we're asked to note the report, and I don't think we've identified any further information that we need. So thank you very much indeed for that, Arlene. We will be kept appraised, though, of the situation, presumably with these further letters going out.
Yes, definitely. I will bring an update.
Lovely. Thank you very much indeed. So if people are happy with that, we can move on to item 2.2 and the subcommittee reports, which is obviously a big chunk of our agenda. And we're starting with the Patient Safety and Quality Committee, and that is chaired by Aruna and Derek. Aruna, is it you or Derek this time?
Thank you, Gillian. It is me this time. I think Derek presented the last time. What I am going to talk about is the PSQ committees that we had on the 24th of September and the 29th of October. The 24th of September was chaired by Derek and the 29th of October by myself. Before I go into the detail of it, I think I would like to set the scene. I think everybody is aware about the stresses and strains and the operational pressures that we experience across the NHS. And we are not exempt from that here at ESTH. I think it's fair to say that we are under a lot of pressure, and our staff are working incredibly hard to deliver a safe service. So the focus very much at PSQ has been one of so what, and how are we ensuring that our patients still receive a safe service, if you like, given the pressures in terms of staff and morale and fatigue and elective care, so on and so forth. We are in a perfect storm, and we see that across the NHS. So it's with that backdrop, really, that I would like to start on the report. At every PSQ, we start off with live issues, and that live issues and operational challenges does take up a significant amount of our time at PSQ because they are significant. I think some of which has been touched on today. We spoke about ED in spite of, you know, the volume coming in the door and the type of cases coming in the door and the ambulance waits, I think it's fair to say our organization is doing exceptionally well, and particularly on the patient safety side. Indeed, it's fair to say that we observed that the initial assessment was too long, and we had a report giving us assurance really that in spite of the fact that the initial assessment was long, our sickest patients continue to be prioritized. And I think that is really important. So I think from a public point of view, you may find that you're waiting a very, very long time in ED, but actually from a safety perspective, we are prioritizing those that are sickest. So, patient harm is kept to the very minimum. In terms of then going back to the live issues, we had a shortage of blood tubes that has now dissipated. I'm glad to say the local ambulance services is a problem across the board. And as I said, from an ED perspective, we're doing everything we possibly can to alleviate that and really to look after our patients. From a COVID standpoint, I think we've touched upon the fact about vaccinations and the impact that can have on community services. We're well aware of that. And I think it's in hand. And as I understand, actually, we have mitigated those staffing issues. On the operational challenges, as I said before, there's a lot coming in the door, but our winter plans are well underway. We continue to see a very high volume of mental health presentations, both in children as well as adults. Again, it is a national problem. We are well aware of it, and we're working with our mental health trust colleagues to work the best options really for our patients. Infection prevention and control. I think Arlene spoke to us about what we're doing with all the historic nosocomial infections, but I think it's fair to say our estates continue to challenge us from a nosocomial point of view. We're not out of the woods, but as Arlene rightly said, every time we learn more and we learn to deal with things differently, but there is no taking away that we don't have enough single rooms. Our estates are always going to be a challenge. So I think we continue to have this as a topic on PSQ, every single PSQ to sort of get a handle on it. Sadly, we did have an outbreak of aspergillus in St. Heliers ITU. Lessons have been learned from that, and we continue to receive reports of assurance and next steps at PSQ. I spoke about initial assessment times, and we've had a report on that. We get an update from maternity at every PSQ, and I'm, again, stresses are faced in maternity. There is a national shortage of midwives, but I think it's fair to say we have plugged all our staffing shortages with new midwives. So, we've done, again, everything we can. This is a national problem. Patient experience report, wonderful success on the letters to loved ones. We received a report on that. Identification of the top 5 languages that are used in the trust. We had suspended the friends and family test from March 2020 to December 2020. That has now been reinstated. The focus really is to get more people engaged. So if people are listening in, please do fill out friends and family. We want to hear from you. From what we have received, actually, we have acknowledged that pain management is something that we need to stay focused on. So that will be something we'll be looking at PSQ. We received several other reports. I think the one to point out really is the good news is on the medicine management plan. The final action plan has been completed, and we are now closing that down. That was a CQC inspection outcome that has now been shut down. We do get SIs. We did have a larger amount of SIs this month. We have isolated the themes related to those SIs. Indeed, we have done an audit report related to, falls and fundamentals of care, and we will be, having regular oversight and gaining assurance in terms of action plans and what we're doing about the themes coming through on our SIs. That was all I was going to say. Any questions?
Thank you, Aruna. That was very comprehensive and helpful. Thank you. Any questions for Aruna arising from that report? I can't see any hands. I think that must be a result of the thoroughness of your report, Aruna. So we're asked to note that report, which I'm sure we're happy to do. So that takes us on to the Finance and Performance Committee. Anne.
I think I've managed to unmute myself. I'm never quite sure, but if I'm sure you'll signal if you can't hear me. So the report that you've got in front of you covers the meetings that we had at the end of September and at the end of October. And of course, with the Finance Committee, the October figures supersede effectively the September figures. So I won't go through the month 5 figures. But I guess the key highlights are that in terms of spend to date, we are sort of in and around plan. 1 month we're slightly ahead, 1 month we're slightly behind, but we're pretty much on plan, which is a good position to be in. Similarly with SIPs, we're sort of in and around plan, cost improvement programs, I should say. But obviously that's incredibly challenging given some of the stresses and strains that the trust is under. And I think the point to note there is that whilst we are delivering cost improvement programs, a lot of those are non-recurrent, which helps us in year, but leaves us with a starting deficit for next year. I don't think we're unusual in that compared with other trusts, but it is something that we need to bear in mind. We monitor quite closely the capital program. We've got quite an extensive capital program for this year, and our plans exceed our current budget. But the committee has assured itself that if we need to, we could take steps to reduce our spend in year. We're actually slightly behind plan on our spending on capital. And I think that's because typically capital spend tends to be back-ended towards the end of the year. And we have received assurance from the executive that we will actually catch up and spend the money. We've taken a few business cases through the committee. In September, we took a business case around increasing the cardiac cath lab service. And in October, we took 2 business cases around waste management and a satellite renal dialysis service, which we will be considering in a later part of our meeting, recognising the commercial confidentiality of some of those aspects. We also look at performance, and I would absolutely reiterate all of the comments that Aruna made around, I think, given the pressures, actually, I think the team are doing incredibly well across the system. And I suppose our focus on it is clearly we want to know that we are achieving targets, but it has an impact on the money that we receive, because there is an elective recovery fund that if you meet certain targets, you can get additional money. And I think we've done reasonably well over the first half of the year. The challenge is that the targets have changed for the second half of the year, which makes it much more difficult to achieve some of those targets. Having said that, as we start, we're doing quite well against the new targets. But that fund, how much we get of that fund will have a big influence on where we end the year, because that's it's a kind of fairly big unknown, and it's a fairly big chunk of the gap between our current funding and what we need to break even. So obviously that will be a really important an important factor on whether or not where we end up at the end of the year. We regularly review risks. We did in October, we agreed an additional risk around the operational challenges that we've talked about. I think one of the things that the committee has recognised is that some of those risks have been there for quite a long time and they haven't moved substantially. And I think we're looking forward to the opportunity to, as part of our new group structure, to rethink how we look at risks in the committee to make sure that we are getting really underneath some of those risks. My last point, and Rakesh's final finance committee will be actually later this month, but I just wanted, slightly ahead of that finance committee, I just wanted to recognise his huge contribution to the finances of the trust over a number of years. I think I wasn't here, but people have told me that when he arrived, the finances were in a much challenged state, and that he has introduced rigour and professionalism. And when he leaves this trust, he will leave the finances in a hugely better place than he found them when he arrived. I just wanted to put on record the committee's thanks, my thanks, but the committee's thanks to him for all that he's done. And pause there.
Thank you very much, Anne, and I will certainly be picking up Rakesh's contribution to the board at the end of the public meeting, but thank you very much for those comments. So any questions to Anne? Another comprehensive report, Anne. Everyone's looking very silent today. Well, I can't see some people, so I can't say they're looking silent, but even those whom I can see clearly have read their papers carefully, listened to what you and Aruna have had to say. There are I can't see any hands. So we'll note that report as well, Anne. And that takes me on to item 22C, the People, Culture and Equalities Committee, EDI focus, and that's you, Martin.
Thank you, Gillian. And I'm going to try and go behind some of the words that are in the report here, hopefully so that the public can understand some of these issues better and what's behind the jargon. So firstly, the structure. We have two committees. Because of the importance of equality, diversity and inclusion, it has its own committee, which I chair. And I also chair one which is on people and culture, because clearly the whole people space covers a massive range of different issues. And there are slightly different memberships in both. I think in terms of equality and diversity and inclusion, what we can say is that whilst the NHS has lots of problems and issues in this area, our relative performance is from average to good. And we measure the relative performance particularly by looking at a number of measures in what's called the WRES and WRES. So one is about race, ethnicity, etc., and one is about disability. And these are unique to the NHS. They're a combination of relevant staff survey results, so questions about things like, have you personally experienced discrimination at work? And there are also statistical measures by looking at things like the candidates who applied for a role and their probability of going from a shortlist to offer, depending on their whether they were white or BME. We then compare particularly with other acute trusts in London and other big metropolitan areas, because if you look at it nationally, it tends to just reflect the demographics of the UK. There are significant rural areas where there are very, very small populations of BME, whereas in hospitals like ours, it's a very substantial proportion of our staff. So you might remember that at the last committee, I talked about the results and the action plan, which we agreed for the workforce, the WRES one. And since then, we've done the same for the WDES. And these are published. They're published by us, but they're also published so that you can compare trusts nationally. On the disability one, a couple of highlights. There was a significantly higher probability of staff with a disability entering a disciplinary process compared to those without a disciplinary, which we're following up on. There was also 23% of disabled staff reported they'd experienced harassment and bullying, which we're looking into and also working with our Freedom to Speak Up colleagues around that. The other area that we also look at is patient experience. So it's not just about staff. We also look at patient experience, trying to see, make sure and assure ourselves that there aren't any EDI issues in how patients experience the care they have. Gillian's already mentioned the veterans. We also have a very active carers network, which is clearly a vital role. And turning to then the People and Culture Committee, not surprisingly from what you will have seen generally reported, staff wellbeing has been a huge part of this agenda. We know that we, in common with other parts of the NHS, have a workforce under enormous pressure and who are very, very tired after what they've had to endure. And I know we've all got a huge amount of respect for the work that they do. What we can do is to provide as much support as possible. And I divide that into professional support. So obviously we have access to professionals in the way of psychologists and occupational health services for where people have specific problems. We've also done a huge amount of education, particularly of line managers, to understand and look for the symptoms of stress. And there's a great deal of support material which is available for people themselves and for their line managers, tools, practical stuff, which is of a great deal of use. Having said that, it always seems to me that one of the biggest causes of stress is actually a lack of staff. Not really surprisingly, you know, most of us would find it much tougher to work and to do our work to the standard we wanted to if we were short of staff. And clearly retention and recruitment in the NHS has been a massive issue for a long time. And whilst it's not our first choice, we have embarked on a very substantial and now very successful international recruitment of nurses. So although this isn't new, a few years ago we did pause on it and were concerned about the length of time and the costs involved in doing this. However, by combining with a number of other trusts across London in a collaborative way, we have managed to participate in a highly successful programme, which even in these difficult times of people moving internationally with COVID, has resulted in a significant increase in the number of nurses, with more in the pipeline. And actually, we know from previous data that the retention of these nurses is usually very high. So that certainly helps with the business case for doing this. That's all I'd like to cover for now, but I'm happy to take any questions on the many different aspects. Thank you.
Thank you, Martin. So the two committees there, well, two meetings with different focus that you chair. So questions to Martin. Chris.
Thank you very much, Martin, for that. Just on the matter of veterans, and I don't know which of your groups this comes under, but Armed Forces veterans are entitled to priority healthcare in certain situations. And I just wondered whether one or other of your committees, possibly the disability one, monitors whether we as a trust have got the processes in place to facilitate that situation. Thank you.
Good question, Chris. Martin?
It's a very good question, and I have to be honest and say I don't know the answer to that. I don't know if any of our...
I can come in there if that would be helpful.
Okay, thanks.
So as the Veterans and Armed Forces champion, Chris is right to say that there are in certain circumstances there is priority of access, but fundamentally it's about ensuring that there isn't a negative impact on members of the armed forces community because the fact that they serve either or have served or for their family members to ensure that they get equality of access is the principal issue. For those with a war disablement pension or an armed forces compensation scheme payment, it is if in effect as if there are two patients of equal clinical priority and one of them happens to be the injured veteran, then they would take the place first. But it's sort of in quite narrow circumstances where there is a priority of access, as opposed to it's ensuring that members of the armed forces community aren't disadvantaged because they or their family members choose to serve the country in those ways. But one of the things we are doing is setting up the ability to capture members of the armed forces community in our patient administration systems to be able to then monitor these sorts of things and to understand sort of uptake and how we're providing effective support to them.
Thank you, Peter. Anne.
So thank you, Martin, for a very thorough report. Part of your report talks about the committee feeling more progress was needed in relation to bullying and harassment, particularly in respect of our BAME staff. And I wondered if the committee was assured that there was a proper action plan in place that was likely to lead to the right sort of outcomes, i.e. reducing the amount of bullying and harassment.
Yes, thanks. I think we are assured in as much as we have recently completed the action plan for the res results, and well, it covers res and open test, and that was one of the key areas. I think the other aspect of this, though, is what other data do we have on this, and what other groups can help us? Clearly, freedom to speak up is a key one, and I think also one of the things that we have decided to do is to make sure that when we get this year's staff survey results, we drill down into the lowest level of data possible, because it is possible then to look at the questions such as have you personally experienced discrimination or bullying and harassment from colleagues or your line manager. It is possible to look at that in that detail, and that's part of a broader change of theme where we're placing much more emphasis on individual managers. And then obviously when you uncover that, you need to look at that data. The other thing that might be of interest is that I personally have done a lot of work recently to analyse the data on BME, on the question of bullying and harassment. Because whilst and it's a big subject, but whilst it's become the norm to group staff together as BME and white, we all know that within that BME category, there are significant different ethnic groups. And we do actually have the data, not perfect, we do have the data broken down by those different categories. And there are very substantial differences in when you look at the data at that level. And when we get the new staff survey, that's something that I want to look at more. And the other thing actually which comes out of that, which I think is relevant to it, and go back to your question, I think we are assured, but I think there are some things we don't fully understand, to be honest, if we base it on data. So for example, most people probably not aware that if you looked at engagement in terms of how positive the results are from the staff survey, the BME group are much more positive than the white group. It's only the aspects of bullying and harassment and discrimination where there's a problem, which is counterintuitive, because normally it would affect people's overall feelings about their employment. And I think that goes back to some groups are experiencing high levels of bullying and harassment, and some are experiencing less than white colleagues. So I think we need to understand a lot more.
Thank you, Martin. It's really interesting. Of course, you shared the data with me, and you do need to drill down more into some of these things. Now, Peter wants to come in, but I've seen both Jacqueline and Saskia indicate, and I suspect it's on this point. So if Peter, you don't mind just holding for a moment, thank you. Jacqueline and then Saskia.
Julian, would you mind telling me if Saskia went first, because she might say the same thing? Is that
Not at all. That's absolutely all right. I did wonder whether I should say Saskia, Jacqueline, but because I'd seen you in the order that I said, I stuck to what I'd seen. Saskia.
Thank you. I do believe that may be the case. So it happens to be an action on the WDES action plan. It doesn't matter really where the action is captured. However, as a step change, we are creating a people board, which is exec-led, staff-informed, which will drive the programme people space, and it will incorporate and encapsulate all matters people. So culture, ED&I, staff survey. One of the first tasks, I believe, of the board will be to get good data and to do the diagnostic in relation to all the data sets that exist there. There is a lot of information, quantitative and qualitative. And the idea, one of the ideas, to get ahead of the curve, to look at the matters that are coming up and to do something about them, rather than perhaps traditionally organisations look at data after a year. So thank you, Jacqueline.
Was that it, Jacqueline, or do you want to add to what's?
No, I think Saskia nailed it. This is about the way that we treat each other and behave, regardless of race, colour, where we work, and how do we change the culture and behaviours of our organisation and help address some of this, as Saskia says, both based on what we've seen and how we go forward. So thank you, Saskia, for saying that.
Thank you, Saskia and Jacqueline. Right, Peter.
Thank you, Chair, and thank you, Martin, for the report. But I'd like to, a slightly different area around, I'd like to just pick up around the recruitment and staffing position, and to reflect positively on the current vacancy and turnover position, where I think on vacancies, that's pretty much bang on the target at around about 10.5%. Turnover is actually just below target at just below the 12% KPI. So that to me is a positive position that we're in. But I'd like to ask Martin about how confident are we about our abilities to sustain that position during the remainder of the year and going forward after that. Thank you.
Yeah, we're very much the national picture here. We know that there is a significant shortfall across the whole of the NHS. We know that there is huge competition for staff, and behind these figures, of course, there are certain specialities where it's even harder. There is still a trend for people post-COVID to be leaving the NHS. I think that many staff are feeling a huge amount of anxiety about the future, and I think inevitably that does affect those who are leaving the NHS, which there possibly is less that we can do about compared to leaving for other trusts. I think also that there's always a bit of a lag here between what we see in the data, which is historic and after somebody's gone, and what people are hearing on the ground about how many people are likely to be leaving. And I'd ask perhaps if there's time for my exec colleagues to comment really perhaps on the latest that they're hearing in terms of whether or not some of the understandable feelings that staff have at the moment, whether or not they think that's actually going to result in people leaving.
Thank you, Martin. Saskia, did you want to take on that challenge of offering such a comment?
Martin, as the chair of the committee and colleagues in the committee have been quite concerned about this for some time for obvious reasons. So what we are trying to do is speaking about getting ahead of the curve, we're trying to look at the resignations that will come online in the next 3 months. So that is something that I believe we've committed to bring back to the next committee at the end of this month. I don't know if my other exec colleagues want to respond in terms of more of the feeling in terms of the workforce. I think the question was, Gillian. Thank you.
Sorry, Gillian is
You,
on
Gillian, but
mute.
you were probably asking Arlene.
Yeah, no, I was asking Arlene. Sometimes when
Sorry.
you press
I know,
on an iPad, it doesn't work, and you start talking because you press the button and it hasn't worked. Arlene.
So thank you, Gillian. I'm not going to presume to talk for everybody, but I think definitely amongst the nursing and AHP staff, there is quite a lot of anxiety, and people are quite tired. And fed up, frankly, some people. And for us as a senior team, and certainly nursing HP teams, we're spending quite a bit more time now just going out and trying to support people where we can. I think that there are little things that we can do to support staff on the ground, you know, just to take that little bit of concern and pressure away from them, so that, you know, even if they're considering leaving, will they consider doing part-time and all of the flexible working things that we can do to make their lives better. So yes, I think there is just general tiredness amongst our staff, which is to be expected. It's about how we respond to that and look at how we can make their lives easier.
Thank you, Arlene. We could end up having a whole discussion on that topic, Martin, but I hope that that's given some flavour, and to you, Peter. So Aruna.
Yeah, thank you, Gillian. A slightly different question, but also I think related to the stresses and strains. The statutory mandatory training, we're still kind of quite way behind, which obviously impacts on service as well. I just wanted to get a sense of, when do we think realistically we could be back to our aspirational 85%?
I think that's probably best for Saskia to answer.
Saskia, would you like to have a go?
Thank you. So the figure as of today is 73%. So it is going in the right direction, although I take on board, Aruna, that it is incremental and it's not going in the right direction as quickly as it needs to and as we would like. Now, I also believe that we took away a commitment to bring a trajectory to the PC meeting that is at the end of this month. So that's the position today, going in the right direction. Further work to do, but it is happening. One of the differences that I've noticed in behaviours is managers actually seeking out the data so that they can do this work and make sure their people are doing their statutory and mandatory training. We do provide the data, but I've seen a rise in people actually seeking out the data to enable them to make sure that their people are undertaking this training.
Perhaps a bit controversial, but I would personally recommend that one of the other things that we could do is to look at what is statutory and mandatory and prioritise it, because the premise in your question, Aruna, was it impacts service, and I'd suggest that some of it impacts service more than others. There's a whole mixture in there, and you really need to ask the question, why is it mandatory? And be realistic that people aren't going to find the same amount of time to do this stuff. And if they're not going to find time to do it all, can we make a realistic target by reducing or at least prioritising what needs doing now and what will have to wait till after we're over the winter crisis?
Thank you, Martin. That was exactly I think we need to think laterally. So my question was loaded in terms of what is the expectation. Yeah. And is it even realistic that we'll get to that point? And yes, it was loaded, and you know, we need to think laterally about this. We can't be expecting people to do all sorts of trainings. Let's do what matters.
So the problem with that, which I completely understand, is that the question of what matters, there is no consistent answer, I think, or it's difficult to get a consistent answer. But both Arlene and Jacqueline have indicated they'd like to contribute to this. So Arlene first, then Jacqueline.
So I wanted to say, on the question of what statutory and mandatory, statutory, so that's that is what we are required to do. But the training team, so Saskia's team, did spend some time last year during lockdown helping us to work out what we needed to prioritize. So that work has been done. I think one of the things that we are still struggling with a little bit is about how we get the correct records onto ESR. So we've moved onto ESR, and what we're finding is quite a number of staff have completed the training, but it's the record bit that is lagging. So there's some work to do there, which we are working on. I think definitely our subject matter experts, so in my team and in the clinical teams, are trying to ensure that they have at least local records that we're able to transcribe, but that I think is going to take a little bit of time. So I think, as Saskia said, 73%, we could see that quite easily rise to 80 and above when we have aligned the electronic records with the paper records, but there is work going on to do that.
Well, that's very encouraging. Thank you, Arlene. Jacqueline, your hand's gone down. So yeah. Right, any other questions? So I wanted to ask a question, if I might, Martin, and it's linking a couple of points. You made the point about bullying and harassment, and there's still too many staff, particularly BAME staff with a disability, but also other staff whose experience is not as we would want it to have. And you talked about managers having been given training to help staff with their mental well-being. And I just wonder how the committee kind of keeps track of all of this. Because for me, the quality of immediate management is the key to happy, fulfilled staff, and happy, fulfilled staff equals good service for patients. So I wonder how the committee is paying attention to this whole question of the quality of management throughout the organisation, from the very, and I'm talking often about first line supervision and immediate management, because that can have the biggest impact on people's experience. Thank you.
I think that there has been a shift of emphasis. In my view, most of the initiatives that have been done very much at a trust level. Most of the data we look at is at a trust level. We'd actually have very little data which talks about the performance and quality of the immediate line manager. But colleagues will know that so many times all the research says that that's what matters most to people. So I think where we are making progress is in things like the well-being one. But if I go back to the bullying and harassment, the fact is that there is a huge difference between what is reported in the confidential anonymous staff surveys as the incidence of bullying and harassment, and people's willingness to speak out and say those cases. Because clearly, if those cases had actually been reported, either for Freedom to Speak Up or through HR, then the numbers of disciplinary and grievance cases we hold will be much, much higher. So for me, the root cause at the heart of it is we have to understand why it is that even with all the things that the NHS we have put in place in recent years, there is still a reluctance to disclose when incidents have happened. And in my opinion, part of that is also to be very visible about the action we take when it is, when there is a problem. And that in itself, I think, will then improve the quality of the line management that people receive. But I completely acknowledge that we do need to find a way to understand better what people's lived experience at work is. And a lot of that is to do with the behaviour of their line manager.
Thank you, Martin. Jacqueline?
So where to start really, but I think there's several bits here, to use one of your phrases, Gillian, with bits of straws in the wind. I think the first bit for me is really triangulating all the data we have, because there's bits of data and that gets fed to execs, to NEDs as well, but doesn't get fed to execs. So we need to address that in a helpful, supportive way. We need to triangulate the data we get, both the formal and the informal, because then that helps us dig down into the areas that we really need to support and change. And one of the things we've had, I won't name the particular area we've got, where we've had over quite a number of years issues coming out that we've tried to address by listening events and doing things differently, and we can't get to the nub of it. So we've started to employ a different way of doing that, using a different type of approach with an external person to try and get underneath that. But there's something I think is right around triangulating to units and giving them that support. There's also something about what we can do. We've got some good basis with the respect work, but we recognise that the respect work has gone so far, but we've not really embodied it in the organisation that's very clear about both, we do a lot of celebrating when people actually behave well. We're not very clear about the consequences when people don't meet the values and the behaviours written in the values. But also in terms of that triangulation, and I can't, because we've not done it yet in that way, but I can only talk about St George's. We also know that a lot of our lower grade staff, our band 2 staff, who also tend to have a higher rate of BME staff in there, their line management is often the area where actually we see poor leadership skills, because we haven't taught them. They've been good at their band 2, but they're not as good at the band 4 because we haven't actually given them leadership development. But we focus all the leadership development at the higher banded people. So there's quite a lot of work for us to do, both within our executive led people committee, as well as how then I think the bit for me, I think we're just trying to get to now is how we really assure the subcommittees of the board, rather than trying to do a mixture of both in the subcommittees, because I think we really need to get underneath that data in a more refined way, and also what our actions are. And I sort of agree and I don't agree with Martin. It's about being very obvious when people have had action taken against them. It's difficult whichever way you go with that, Gillian. And I think we just need to work through the processes we have and be clearer about what we're doing in regards to that, to the board, when we need to, rather. And I would need to think about heads on sticks outside the gate. I know that's not quite what Martin's saying, but I'll just to be when people have been punished for poor behaviours or racism or bullying and harassment. Just need to work that through.
Thank you, Jacqueline. As you say, it's a big subject, and there is work underway. I think my sense is that we need to join some of these things together in a different way, and there is no doubt that the group that you and Saskia have already referred to will be a big help there, and the material that then comes up to the committees that Martin chairs will be in a better position, I think, to do the assurance role. So Arlene, you've indicated.
If I may, just possibly the final word on this. So I think I'd like to say that in the 4 years that I have been here, we have seen a marked improvement in this area. So we must be careful not to throw the baby out with the bathwater. We are looking at changing culture, and the culture, as I know it when I came here, was it was really poor, to the point that I wouldn't even go out and recruit internationally because I didn't think our culture could support it. I think we've moved a long way, and all of the things that we are putting in place now, the group that Jacqueline and Saskia have spoken about, I think all of that will improve. Martin coming on board has helped as well in terms of that NED function and giving us that look from the outside in. So I think we are on a journey, is my sense. The lived experience on the ground is getting better, but we are expecting people to do things that and quite a number of our middle managers, certainly in nursing and HPs, have been here for a long time. And to change that culture is going to take some time. So we mustn't, do ourselves down. There is a lot of progress, but more to happen. That's what I'd like to encourage us.
I think that's a nice summary, Arlene, but I'm going to give the last word to Martin.
Yeah, I would endorse what Arlene said. And I did mention that our relative performance amongst what really matters, similar trusts in London, is from, when I say average, I mean around the benchmark to good. So that is really important. And that's all I'd like to say.
Thank you, Martin. And it is absolutely the case that that's how you opened your introductory remarks. And I think the tenor of the discussion has been, yes, lots of good things, but it's the detail underneath that we need to make sure that all staff's experience is at the level of the best, really, and that all staff have got the managerial support that they need to do their job as well as they possibly can. But I think it's been a really helpful discussion. And thank you to everybody who's contributed. At the end of all of that, we're asked to note the two reports that Martin introduced, which I'm sure people are happy to do. And that takes us finally in this section to the Sutton Health and Care and Surrey Downs Health and Care report. Chris.
Thank you very much and good morning. Pleased to give this report. At the top level, just to reiterate that governance and assurance meetings have taken place for both Surrey Downs and Sutton Health and Care since we last met, and the two boards have continued their development. On the paper that you have, which I will assume people have looked at, we've aggregated together the community services report for Surrey Downs and Sutton Health and Care, because just to confirm, they are two separate organisations underneath Epsom St Heliers employment and leadership, but they're so similar in what they're trying to do and their initial outcomes that it's just easier to put them together rather than have two reports which are more or less identical. Just wanted to make sure the board was aware that we do, as well as having an executive director in the person of Thurza Sawtell, who of course covers both boards, we also have a joint executive director for nursing and quality who covers both boards. This means that we can make sure that good practice or problems that arise on one side can be reflected on the other side for learning purposes. I think in terms of the operational side, both services have got back to full working. There is, of course, just as there is with the acute trust, a backlog that needs to be worked through, and that backlog is being worked through. Certain services provide a greater challenge than other services, but those services are being prioritised and ways looked at as to try and improve that backlog for patients. So I think I would take that part as read. There's still work to be done to improve the waiting times, but we will be working on that. And we've been involved in both areas on the development of the winter planning process to support patients in the community, but also to support the acute trust. The risks got 4 consolidated risks above a level of 16. I think they won't be strange to anyone in terms of they are to increased activity, concerns around workforce, though our workforce vacancies rate is on a par with the acute trust. One thing I just wanted to pick up was about the health and well-being of staff impacted by COVID, but it's also the pressure of seeing these large waiting lists that have developed down to COVID. Knowing that you've got more and more to do is a stress on individuals who are working, and we need to reflect that it's not just about COVID, it's the general work experience. And there are some financial issues around the way that the community services are financed and how they would therefore be able to manage an increase for demand and activity. In terms of the Sutton Place specifically, we held a large OD session 2 weeks ago, which was good to get everyone in the same room, not so usual these days. And we had a wide range of stakeholders from both from community services, social services, and the voluntary sector and patient representation. And that was a very good meeting, looking at what are the challenges that are there for delivery of care, health and social care in Sutton, and with a particular focus on staff, with a session that involved identifying what are the pressures for staff across the whole field, and what mitigations can be done to try and improve their work experience. And I thought that was a positive thing, because we can all talk about the pressures, but you've also got to find some answers to it. And we continue to work with what our place is in Sutton within the South West London system. Surrey Downs Health and Care Partnership have continued with their organisational development, and as you heard from Jacqueline, we've had some high-level visits to Surrey Downs Health and Care Services. The final thing I just wanted to mention was for both Surrey, well, it's a national programme, so obviously for both Surrey Downs and Sutton Health and Care, is the Ageing Well programme, and I just wanted to give a tiny bit of flesh to that, because Ageing Well is about trying to improve the quality of care that can be given to people with frailty. And there are four or five main areas. That one is around the development of multidisciplinary teams, so that's GPs, community services, and social care services, to look at those highest risk patients and try and reduce their risks and improve their care. Secondly, there's the support. There's an arm which is support for unpaid carers, family, usually family, but may also be friends. Thirdly, there's the rapid response teams, which we are mandated to supply for patients. And this involves responding for urgent requests for care, community care within 2 hours, and we are working on that, and there is financial support to do that. And finally, there is care from social and community services for people living in care homes and care home providers, and a lot of work is being done with that within Sutton and Surrey Downs. Within Sutton, it's being built upon a programme that existed 5 or 6 years ago called the Vanguards programmes, where Sutton was a national exemplar for the support that was given to care homes by Health and Social Care. I will leave it at that. I'm happy to take any questions or comments.
Thank you very much indeed, Chris. Anne?
So a comment rather than a question. I'm afraid I missed the declarations of interest at the beginning when I was struggling to get in. But of course, wearing my chair of the South West London Mental Health Trust, we're very much engaged in the Sutton Place. So I should have probably brought that to the meeting's attention. I don't actually think it's a conflict, because I think the work that we are collectively doing in Sutton is a really exciting opportunity, where not only are we looking to integrate community and acute in terms of physical health, but integrating physical and mental health, which I think has the potential to be a model for the rest of the system. So very much welcome that approach.
Thank you, Anne. Are there any other questions? Otherwise, I have one. You talked about backlogs, Chris. Do both the committees that you chair monitor the backlog situation carefully, so that we understand the risk we're carrying through backlogs?
Simple answer is yes. It's always a priority area on the monthly quality meetings, and with the areas that are most challenged being highlighted, and what mitigations. I don't know if Thurza wants to add anything to that.
Thurza, if you're out there in the ether somewhere, did you want to?
No, only to say that we have improvement plans for the areas with the highest risk, and those are monitored as well. So not just the outcome or but also how we're improving.
And I guess what follows from that, Thurza, is are we improving at the rate that enables you to feel content about it?
Mostly we're exceeding the rate of improvement. So I think we're doing very well. Probably the area which has held us back is the increase in referrals from general practice. So we monitor both the referrals coming in and the backlog. So it is meeting that demand and capacity. But yes, we are on track or exceeding our expectations in terms of the backlog.
Thank you very much indeed, Thurza. Any other questions? I can hear myself echoing, which is completely distracting, but there we go, the wonders of technology. So we're asked to note that report, colleagues, and that takes us on to item 2.3, the integrated performance report. And Ruth, I think we're going to start with your items.
Thank you very much. So Arlene and I are going to cover the safety and quality indicators, and I'm really going to pick up key points that haven't been highlighted during the PSQ report and feedback. In terms of mortality, I think the page is self-explanatory. I do want to pick up some key points on the second page, which gives some of the demographic data around our COVID presentations and admissions. We've had discussion earlier on around the pressure the hospitals are under. At the moment, as you'll see from the data here, the number of admissions we have in our beds who have a positive test for COVID is in the order of 7 to 10% of our inpatients. So that figure is fluctuating, but actually I think it's fair to say the fluctuation has oscillated around the same point over the course of the last 6 to 8 weeks. One of the points I did want to pick up will, I know, come up as a question later on, and it's around the age profile of patients admitted and vaccination status. I think you'll see there's a lot of information here. You'll see that older patients who have had a double vaccination are much more likely to be admitted than younger patients who have had a double vaccination. And I think that overall, if you look at this, 57% of patients admitted to our hospitals have had 2 COVID vaccinations, but a higher proportion of that 57% are over 70 as compared to under 70. That said, if you then split it into the number of patients who require intensive care provision, that's when you very much see the benefit of COVID immunisation. And we've got some data later on we're going to share that really shows how the COVID vaccination, and particularly 2 immunisations, is protecting very significantly against the need to go to intensive care. The other points I just want to pick up from the safety and quality pages, I want to focus on patient experience. We've heard around some of the proactive work the team doing, but I think it's really important to highlight here that the work they're doing to deliver on complaint responses continues. Our performance in month had dropped to 81.8%, which reflects, I think, divisional pressures, particularly in medicine. So that remains an area of very significant focus because it's really important that we get our complaint responses out in a timely way. And the final point I wanted to pick up on relates to friends and family test, which gives us such invaluable feedback. We've seen the rate of return for our inpatients drop recently. And so that is now an area of great focus, as is the recommend rate for patients attending our A&E departments. So there's a huge wealth of data in these pages, but there's some key points there. And as always, very happy to take specific questions.
Thank you, Ruth. Are there any questions for Ruth? I think it's probably better if we take questions go as each exec has spoken, otherwise we might lose points if we do it the other way. Martin.
Yes, thanks, Ruth. A couple of questions. There was a lot of concern that it was going to be a particularly bad flu season. which certainly media-wise isn't something we have, but I'd be interested to understand what we're seeing in that regard and what our thinking is about what might happen. And the other one, I don't know how possible it is to answer this, but when you were talking about the sort of demographics of the COVID patients, I wondered if you, from a clinical point of view, are able to see any trends yet in terms of the length of time since people had the vaccines.
Thank you, Martin. So I think in terms of the first point around flu, we're talking about flu vaccination later on the agenda. So flu usually peaks after Christmas. So we are anticipating the numbers are going to increase as we get through December and January. We have had some, patients admitted who have had influenza virus isolated, but actually I think we'll see those numbers increase more in December and January. That said, we have seen a number of significant other respiratory viruses. So it's not just flu, it's not just COVID. We've got para-influenza, we've got respiratory syncytial virus, we've got a whole cacophony of winter viruses that we are very much seeing at the moment. So I think the flu admissions will increase over the next 6 to 8 weeks. In terms of the question around immunisation timing and admission, that is something we are now capturing on a daily basis as part of our daily set of data that we upload and share with execs for our COVID patients. I think there is no doubt that the timing of the booster, that the third vaccination at 6 months reflects the time at which we know antibody levels and consequent protection for. So I don't think we're seeing anything, Martin, that would go against what we've heard more broadly and around the timing of the third booster vaccination.
Thank you, Ruth. Any other questions for Ruth? No. Could we move on then to Arlene? Areas that you wish to highlight for us, Arlene?
Thank you, Chair. So there are only a couple of areas on the IPR that I would like to highlight. One of them is on the quality metrics page, and this is about our dementia assessment and referral. And as you would see, it's not where we would like to be. It has got better in the last year. And my team in the form of Dion and her team are working to ensure that we have now got the process set up, but that people are then using the process. So we should see this improve significantly going forward. And it has always been my ambition, as the board would know, that dementia is not just a nursing thing that we need to look at. So I think importantly, the team are ensuring that everybody from transport, porters, everybody does have some education and can support our patients with dementia through the hospitals. So this will improve. On the maternity page, there is nothing significant to report. I think in terms of safe staffing, just to inform the board that we have been successful, and so far we've had 108 new international nurses join the organization since April, and we are on trajectory to have another 20 or 30 by the end of the year. So we are doing successful international recruitment, and these new recruits are ready and they are coming in, and within weeks are able to successfully complete their OSCEs. So we will continue to do some work on that to see our vacancies go down. The only other issue that I wanted to highlight from the IPR was infection control. We've talked a lot about COVID, but as C. diff is also a concern for us and for patients, and currently we are over trajectory. Some of that is due to antibiotic usage, but we have our new antimicrobial consultant started who will focus on antimicrobial prescribing, and therefore I have asked to see a very clear action plan for what we need to do. We first, of course, need to get to the bottom of is it just antibiotics or are there other things? We do look at the other quality key performance indicators, including hand hygiene and all of that. So we will see some work happening in that space as well. And I am happy to take comments or questions.
Thank you, Arlene. So I've seen Chris and Arun. Chris?
Thank you. Thank you very much. Thank you for the report, Arlene. Just on the recruitment of international nurses, could you say something about which countries or areas of the world the people are coming from? Obviously delighted to have new people, but it is potentially slightly a two-edged sword depending on where people have come from, isn't it?
So thanks, Chris. I think it's important to say that we are committed, as the rest of the NHS, really, to ensure that we ethically source patient nurses from internationally. So the Philippines, we know, has government. We have government-to-government arrangements with the Philippines, so they actually grow nurses for export, as it were. And I'm not want to talk about individuals as goods, but that's what they do. They train nurses with the very clear knowledge that many of them will go overseas to work. So we have some from the Philippines, India, and we have some from India. It's the same. We only recruit from areas where there are surplus nurses, and we have a very clear code that we're working to with regards to that.
Thank you very much, Arlene. Aruna?
Thank you, Gillian. I didn't want us to leave this without acknowledging some of the really great work as well on the quality metrics. If you look at the emergency readmission down to 5.6%, which is kind of, one of the lowest rates we've ever had. So just to acknowledge that in spite of all the pressure from a patient, that's a huge indication of patient safety. And really to acknowledge that, and also to acknowledge our VTE compliance and discharge summary completion within 24 hours, all heading in the positive direction in spite of the pressures we face. And finally, really to say we do must screening. Arlene can correct me if I'm wrong. We just haven't captured it here. So that's also a really positive step in terms of fundamentals of care and taking us in the right direction towards, dementia screening. Fundamentally, these are all going to help us, improve the fundamentals of care.
Yeah, thank you, Aruna. Can I just add quickly before Chris comes back in that we have recruited a nutritional nurse specialist, and she will start in January. And one of the outputs that we would expect is to see our must assess risk assessments and management care plans on here. So thank you, Aruna.
Thank you both. Chris, you wanted to come back?
Sorry, if I might, on Aruna's point about reduced readmission rate, this is partly a reflection, I'm sure, on the better integration that we have between the hospital and our community services, so that the patient's discharge is more joined up and therefore less likely to fail and lead to a readmission.
You're so right, Chris, and that's the work that Thurza and her teams lead and deliver so successfully. So going to move on then, because we are tight for time, to Rakesh. Was there anything you needed to flag up, Rakesh, from your part of this report?
Sorry, Chairman. No, just to flag, echo what Anne said, that the first 6 months of the financial year, the trust did deliver the small surplus that we were planning for. And just to echo the CIP, we're broadly on target, the cost improvement program, but as Anne said, a large proportion of that is non-recurrent, which obviously will have to be addressed as we go into next financial year. But just one thing to add is we're very focused on paying invoices within 30 days, particularly to small and local suppliers, and we delivered 93% of that target in September. So it's a mandate from the NHS that we do that, and we do focus on that. So nothing more than that, apart from any questions.
Thank you, Rakesh. I think so right to emphasise that because it's not easy for some trusts to do it, and it's to our credit that we reach the levels that we do. Any questions for Rakesh? Can't see anyone. Thank you, Rakesh. Saskia, anything you wanted to highlight from your page?
Thank you, Chair. If I may, appraisals. We've spoken about sickness, mental health and wellbeing, statutory, mandatory training and turnover already today. In terms of appraisals, the KPI today is 49, so an increase from 43, which is the figure in the board pack, but not at 85, which is where we need to be. And we've already mentioned in the meeting GLAM campaign to encourage our people and managers to have the appraisals. We are making it clear at many opportunities that it's an expectation of leadership that they undertake these appraisals. A key indicator in showing our people that they are valued. We're providing data, we're providing training and coaching as required to enable to do this, because it's not simply about compliance, it's about the quality of these appraisals as well. And whilst stating yet again that people are trying to do all of this in a challenging context. We spoke about line manager capability, and clearly appraisal is very important in that, as performance management can be addressed through that mechanism. Thank you, Chair. That's all I wanted to add.
Thank you, Saskia. I think those points are really well made, and I'm glad to see that you chose that to highlight to us because of its importance in so many different ways. So that takes us finally to Philippa, who I think is here today rather than Sue. Philippa, anything you want to flag for us on your pages?
Not especially. I think Anne and Aruna have done a really good job of talking through performance, but I guess I just need to re-emphasise that demand for urgent care, cancer and elective care continues to rise. Elective care particularly is at 120% of our pre-COVID levels, and if you overlay winter onto that over the next few months, despite all our extensive planning, that will be very challenging. So I just thought it's important to make the board aware of that. Thank you.
You're quite right, Philippa, and even the language you use is very measured and but doesn't capture some of the intensity, does it, for staff on the ground and our patients who need the care as well. Any questions for Philippa? No? So in that case, we're asked to note the overall integrated performance report, and that takes us on to item 2.4 on the corporate risk register. Peter.
Thank you, Gillian. So the corporate risk register has been through the various committees that we've heard from earlier in today's board meeting, and a number of colleagues have touched on the movement in risks. There's a few that have been resolved, for example, around the management of blood tubes and blood transfusion and our medicines management, which is good to see that we're making progress against those risks, those that are coming off the corporate risk register, but also to acknowledge that there is other changes that are in train and need further review, particularly picking up the conversation from today's board, reflecting some of the board subcommittee conversations around the operational pressures that the trust is experiencing and the impact that that has alongside all of the other things on our staff, and how we make sure that both of those components are properly reflected in the corporate risk register. So there'll be further work during December on those, and then as we move into more group arrangements, we'll also refine those further in the context of how we compare and contrast with colleagues at St George's as well, and how the board can obtain sort of both effective oversight and appropriate assurance of the risks that we face and are managing, many of them on a daily basis. So those are the components I just wanted to flag through. That reflects the conversations that I've had at board subcommittees.
Thank you, Peter. Any questions or comments from colleagues? Peter, I'm sorry, I've just got a question about 2.11, the employment arrangements in community services. That can come off now, can it? Sorry, that should have been a question. Can that come off yet?
Yes, I think that obviously now that staff have GP'd through, then that changes that fundamentals. But I think it's important, as Chris alluded to also and the ongoing sort of the partnership working that we have for all of our community services, that we make sure that we properly reflect those in the risk, but the specifics of the kind of employment status has now been resolved.
Okay, thank you very much indeed. So we're asked to endorse, note the proposed changes that Peter has highlighted, but I think also that 211 can come off as well, can it not? Are people happy to agree that? Yes, I can see lots of nods and a thumbs up. Thank you, Chris. Right, that takes us on then to item 2.5 and the flu programme. Arlene.
Hello, thank you. Thanks, Gillian. Just pressing the buttons does get to you a little bit sometimes. So the paper here is just to let the board, to make the board aware that we are well into our flu campaign for this year. We are doing it alongside our COVID booster program, so that some staff are coming in to have both at the same time. We are committed to ensuring that we achieve at least 85% of our staff having had a flu vaccination during the campaign. So that has started. As I say, this is just to ensure that the board is aware. Many of the board, and I think in fact 100% of the execs have had our flu vaccine. We are using an electronic system this year so that all staff are being sent an email message inviting them to book their flu vaccine or their COVID vaccine, and they get sent a message every week until that has been booked. Staff are also able to go on and let us know if they do not want to have one. So some declinations, and we have had some declinations, and they're also able to let us know if they have had it somewhere else outside of the hospital. So that work is ongoing, and that's just to assure the board that we are undertaking the campaign as required.
Thank you, Arlene. Any questions from colleagues? Can't see any hands. Oh, Martin, sorry.
Yes, thanks, Arlene. How far are we going in terms of, if you define it as people who work in the hospital? Because I realise there's a whole range of different things. I'm aware that we've said previously contractors, etc. But then obviously we've got bank nurses, locums, we've got possibly even, I guess, people coming in on in-sourced arrangements, etc. So how's all that bit working?
So we invite everybody, all staff, including contractors on site, because they are going to be around patients and other staff. Contractors, bank workers, agency workers are all invited. Of course, it's different because some of them won't have trust email addresses, so we won't be able to contact them via the ESR process, but we are proactively getting those email addresses so that we can add them onto the system. So it is open to all staff, and we consider all staff in hospital as frontline workers.
Yeah. Thank you.
That's very encouraging. Thank you, Arlene. Thank you, Martin, for raising the point. So the board's asked to note the paper, agree the recommendations, and commit to achieve the ambition of vaccinating all frontline staff, which I think we would all very much want to support. Yeah, lovely. Thank you very much. So that takes us on to item 3, the Guardian of Safe Working update. And in the absence of Andrew, who's on study leave, Ruth has very kindly agreed to lead on this for us. Ruth.
Thank you very much, Chair. Well, we thought it was important to bring the report here because this is the Q1 report, and clearly there's some important messages and feedback in this report. So for those that aren't familiar with the role, the Guardian of Safe Working supports junior doctors, and junior doctors employed on the 2006 contract have the opportunity to file what we call exception reports if the terms and conditions of their job are not met due to service or other demands. The system works really well actually to ensure that junior doctors do have a safe working pattern and conditions, and also allows us to get in real time concerns about said conditions to be raised. I think it's really difficult looking at this report to draw any statistical conclusions because there are small numbers, thankfully, of exception reports that are raised. What I would want to highlight to the board is that because it's doctors on the 2016 contract that are able to exception report, and because we have a whole tranche of doctors transitioning to that contract, the one certainty is that next time we present this, there will be more exception reports that have been raised and that have been shared. I think the key things that have come through during Q1, most importantly, no junior doctor raised an immediate patient safety concern, and that's a really important negative, I think, to stress. There were concerns in Q1 that in some areas there was a culture of not encouraging exception reporting. And so, as you see in the report, that has been addressed and continues to be addressed with support from our Chief Registrar. And I think the other thing that I hope you'll see from the report is that by filing an exception report, we can actually take action. Through the system of exception reporting, we've identified a doctor in difficulty and have put in place appropriate support and measures for them. And the other thing you'll see highlighted here is that reports around excessive working and hours have led us to make some changes in one of the rosters that we have in place. So the report is here for information for the board to note, and I think to highlight that when presented next time, we anticipate seeing an increase in exception reporting. With that, I'm happy to take any more specific questions.
Thank you, Ruth, and for outlining the key issues so clearly. Aruna.
Thank you, Ruth. It is a really important function, and it is about protecting our junior doctors. And I'm really pleased to see this report, and I'm really pleased that it's being used in the way that it is being used, and identifying areas where people are discouraged, if you like, from exception reporting. So with that in mind, may I ask, I see that Dr. Jalpa Koteja is going to be doing a survey of junior doctors regarding attitudes and behaviours. Could I suggest that this comes to one of our subcommittees, either one of Martin's or PSQ? That's all I want to say, but really very encouraged by the proactive approach here. Thank you.
We'll share those. Sorry, came in too quickly. So absolutely, Aruna, we'll share those survey findings once available.
Thank you very much, Ruth. Chris, I think I saw your hand. Has it disappeared?
Yes, because it was answered my question was answered in the chat. Thank you.
Oh, right. All right. I'm not paying sufficient attention to the chat, so thank you for that. So the action required of the board is to note the contents and that generally trainees appear to be working in a safe environment. There's the point that Ruth's made about new starting LEDs, and to note the reports of trainees being discouraged, and that the board supports the Guardian in discouraging such behaviour by supervisors. I think I speak on all of our parts to say that would absolutely be the case. But before I actually ask everybody to agree that, Saskia, I've just seen your hand.
Sorry, that's user error, Chairman.
Okay, that's fine, no problem. So is the board happy to support those recommendations? Yeah, that's great. Thank you very much indeed. So that takes us on to item 4.1 and the BAF. Peter.
Thank you, Gillian. So this report represents the progress against the key priorities that the board set at the start of the year, picking up both the South West London partnership working and priorities set for us as part of the system, as well as our 5-year strategy. So the draft of the report has been through the board subcommittees that have occurred recently. The overall performance shows that in many areas the progress has been made, but an amber rating means that clearly we haven't made all of the progress that we had initially intended to do in the year, but there is still some scope to bring that back on track in the second half of the year. I think the other thing to reflect on is this is the Q2 report, and some of the dialogue that we've had today also reflects actually the increasing pressure that the trust feels under. So as we will move into Q3 and Q4, it may well be that some of those challenges will flow through more starkly than they perhaps currently appear in the board assurance framework as at the end of Q2. So it's open really for the board to discuss and agree and ultimately approve the board assurance framework, subject to any changes that or comments that people feel we need to take into account as we move into the second half of the year.
Thank you, Peter. I was just momentarily distracted by trying to read a comment that Anne had posted in the chat, which I haven't been able to read. But Peter, I think that point is well made, that this is actually to the end of September, isn't it? And we look at some of these things very much with November in our heads. Certainly I've agonised about whether some of the ambers should be deep ambers, if you like, rather than light ambers. I don't know whether Anne's point was about the limitations of the three colours, because no, it obviously wasn't. But sometimes I wonder if whilst colours have their uses, they're not always good at nuances, I suppose, because they're quite simple. So anybody got any points they want to raise? I'm going to have to see, Anne, what it is that you said in the chat room.
It's about apostrophes and where they sit in between, before or after the S.
Thank you, Peter. Oh, right, okay. Important though apostrophes are, and I think you all know that Anne and I are of an age where we get agitated about apostrophes in the wrong place. Are there any matters of substance, Anne?
There's a slightly more important point than apostrophes. And I guess it's really the approach to how you score things, because it can't be a mechanistic approach. Sometimes you say, well, if we've got 3 milestones in this month and we've done them and therefore it's all very fine and green. But if you can sense a trajectory that's going away from you, I think what I would appreciate is that sort of judgment overlay on the assessment, because to some extent, the whole point of the board assurance framework is what's going to stop us achieving our objectives by the end of the year. Yeah. And if we're kind of on plan, but we expect not to be, then we need to reflect that in our assessment.
Yeah. So Anne, perhaps in previous iterations before you joined the board, so probably 2 or 3 years ago, we had a more refined or a finer detail between both current progress as well as sort of forecast of outturn, and that element forced that more through starkly. But part of the reason why over time that sort of has sort of edged away is that it's to combine into an overall assessment rather than having 2 colours that were often the same, or then to being draw out the distinction between progress to date and forecast of outturn. So I think a bit like the corporate risk register conversation, as we move into group arrangements, there will be an opportunity to also say, how do we do this in a consistent and coherent way, and to learn from each other and indeed more broadly. So I think that's one of the components that we can pick up further forward. But your point's well made, and we've combined these into a single judgment. But as you say, I think when I talk to colleagues around this, is partly it's being absolute as to what progress have we made, but then in terms of the colour coding, that's about judgment and almost feeling, because it's about taking these things in the round.
I don't think there's a perfect BAF process anywhere in the NHS, to be honest. I always read these things with great care and agonise over various elements, and I did exactly the same here. But I think taking the discussion in the round and recognising that we will look to find a system that takes the best of ESTH and George's. Are people content to approve the current Q2 ratings? Yeah. Thank you, colleagues. Right, that takes us on then to the summary report from the Audit Committee. And Peter, that's you. The other Peter Kramer, that's you. Peter, are you there?
Oops, sorry, was I still muted? Apologies. Yes, I was just saying this is my first meeting, but it was a straightforward meeting, so I can be brief. Straightforward is a good thing, actually, because it meant that things were generally in a good place. And I can just highlight a couple of examples of that. Firstly, we had an update on the external audit position on the conclusion of the 2021. We heard our external auditors, KPMG, had signed off their audit opinion. And just a reminder, it was a clean opinion. And of the 4 recommendations for improvements, 3 had already been implemented by the team, and the other will be picked up in the 21-22 audit plan. Alongside that, we had a brief update on the 21-22 position, the forward look, and that seemed to be well in hand. We received 4 internal audit reports, and the one I'd just referenced was actually the EDI maturity assessment, which wasn't formally RAG rated, but what emerged from it was generally a good position. In particular, what was referenced as a positive was the tone from the top on the EDI issues. So again, that's credit to the exec team for the for having set that tone. Otherwise, we touched on updates on counter fraud and cyber, in which training of staff was important and had reached, I think, 80% in the case of cyber. But I take the earlier point about the need to kind of prioritize staffing, and I'd welcome an input to that at that stage, because although both cyber and counter fraud training are important, clearly given the wider pressures, we need to look at that, the full picture. But otherwise, Chair, that's all I'd like to report at this stage. Thank you.
Thank you very much indeed, Peter, and for a very thorough written report. Any questions to Peter? Otherwise, we're asked to note the report. Yep. Okay, lovely. Thank you, colleagues. So that takes us on to item 5. And the first item under 5 is the WDES. Arlene.
Thank you, Gillian. This is a short report, and because I think Martin spoke a lot in his feedback already about the workforce disability equality system, and we are audited, as it were. Our data is analyzed and reported back to us, and we had the results of that, and we have developed a plan, the exec team, working with our network and our lead for equality, diversity and inclusion. We have developed an action plan to address some of the areas that were identified as gaps for us as a trust. I think for me, the most important one of those actions would be the one that looks at how we get staff to be more comfortable about reporting that they have a disability in the first place. And that is about ensuring that we get staff to feel psychologically safe. On the ground, staff will tell you that they don't want to let anybody know, least of all their manager, that they have any disability in case they suffer discrimination because of it, or they are treated differently, or they don't get equal access. So that is one of the biggest ones that we are needing to work on. But like I said, you know, this is all part of our culture change process, and how we get staff to that place is going to be important for us. So in terms of the action plan, the board is asked to note the action plan, which we are required to upload and to the external trust website.
Thank you, Arlene. Martin.
Yes, so just building on what Arlene was saying, certainly as in any organisation, there will be some staff, hopefully less than there used to be, but there will be some staff who are reluctant to disclose, and that clearly is a cultural issue. I just wondered if there's a practical and administrative issue as well, which is simply that you need to make it very easy for people to disclose. Because not all of the gap is likely to be because of that. And the other thing that the exec might want to consider is, you just said about line managers' response, and they don't want their line manager to know. Well, if you have a disability but you don't need any reasonable adjustments, I'm just wondering if the line manager does need to know. In other words, it might be something which is kept by HR, which we need for statistical purposes. But from a practical point of view, I just wonder if it would be worth considering that you again make this distinction between those who need reasonable adjustments, who probably will report it anyway, and those who don't, in which case could offer them that it's confidential to HR.
Yeah, and I think that's a point well made, Martin. I think that we can do some work about highlighting to staff that this is not something that will be made known to your line manager. And I think that's where where staff feel a little bit of hesitation. But as you say, if they don't need any adjustments, then it's fine. And the line manager need not know. So it's about how we get staff to that place. And that's an angle that we probably need to focus on.
I think we need to be quite careful about this. I understand absolutely where you're coming from, Martin, but if we believe, well, as I certainly believe, that a line manager's job is to understand their staff and enable them to be the very best they can be, to give them support, then what is it saying about our managers that we wouldn't want them to understand the member of staff in the round? So I don't need a debate about it now, but I just think we need to be quite careful about doing things for good intentions, and it may be that we have to do that until we've got to the kind of nirvana where we have managers who can fully support their staff in whatever way they need. But I just hate to think that people have got such uncaring managers that they wouldn't want to understand things that affected the lives of the people for whom they had responsibility. But as I say, it's quite, I realise it's just a big discussion and probably not for the board, but I just did want to make that point. We're just noting, because the plan's already been published, use of the trust seal, Trevor?
Thank you, Chairman. This is just for information that the trust seal was used for a lease of Village House in 2 Ashley Road, and this was provide us some much needed residential accommodation for the international nurse recruitment, and to provide them with somewhere to live in their sort of like first months in the country and working for the trust.
Thank you very much indeed, Trevor. So we note that as well. That takes us to any other business, and we've got some sad any other business today. Well, it's sad in as much as we have to say a goodbye and thank you to 3 people, and none of them is kind of leaving today, but before we have another public board, all 3 will no longer be working with us. And the first of those is Rakesh, who, if you had to sum up Rakesh, it would be the sheer modesty of Rakesh and his sheer professionalism, as he has steered the finance ship ESTH from very stormy waters to very, well, he would hate me for saying very calm, but relative calm. And I think, Rakesh, you do that all with in a very quiet and modest style, but we wouldn't want you to move on to your next post in LAS without emphasising how much we've appreciated that calm, professional approach and the great success you've had. Anne made the point when she was talking about your contribution to Finance Committee, but it of course is true to the whole of the board's work. When I think of your contribution to the SETCH and our programme for building the new hospital, but a myriad of other things which would take up too much of the board's time and you would hate, actually, if I'm honest, because I bet you're sitting there thinking, I do wish she'd shut up. But from all of us, Rakesh, a really big thank you for what you've done for this trust. And as I say, the extent to which you brought us financially to a really strong position. The fact that we still got a deficit is nothing to do with your professionalism. It's a structural issue. But I think that you have helped highlight that to the system. And as I say, you could not have done a better job for us. So a big thank you to you, and our very best wishes. Lucky LAS, I think. I'll take comments at the end, but you can see all your colleagues clapping, and I know I speak for us all. The second person I wanted to say a big thank you to was Meg, who will also hate me for this, because there is another very modest person who has held together the governance of ESTH in the same very professional but also very modest way. And as an incoming chair, I could not have been more grateful for Meg and her team's support. They are a fantastic team. They're hugely professional. It's a joy always to read their minutes because I hardly ever need to make any corrections. And those of you who know me well will know I have a predilection for making corrections to minutes. And Meg, we do recognise this is a lifestyle choice for you. And I know you won't have come to the conclusion lightly, and you nevertheless resisted all our efforts to persuade you that you could stay and help us a little bit more. I would have particularly appreciated your help as we get the governance right for the group. So a really big thank you to you as well, Meg, for all that you've done, for quiet professionalism. Seems to be a theme here, doesn't there? And our very best wishes for the future, whatever you choose to do.
Thank you.
Thank you, Meg. And then finally, also this isn't quite in the same league, but Claire is going off on a secondment. So as we all know, secondees are meant to come back, and we have to hope that that will be the case. Claire hasn't been in her current position very long, but she has nevertheless, she was Associate Director for a very long time of comms, and we all admire her consummate professionalism. She's not quite as quiet as the other two, but she's another one who doesn't make a lot of noise, really, which is quite unusual in comms people, really, isn't it? So Claire, we wish you the very best as well as you move across also to LAS. There's another theme here, isn't there, on your secondment, and we hope that you will enjoy that and learn some different things. Certainly the London-wide perspective will be a very interesting one. So that's it from me, but I would like to give Rakesh and Meg, and well, Meg's tried to get her thank you in first, and Claire, an opportunity to respond. But first of all, you, Rakesh.
Thank you, Gillian, for those kind words. Yes, I'm really grateful to have been appointed Epsom St Helier. It's been an enjoyable journey. I really want to thank all my exec colleagues, present and past, for supporting me. Maybe I'm not as modest as you think I am behind the scenes. So it has been difficult at times, but the support of the exec colleagues and the board, both present and past, has been essential. So I want to thank all of you, really, and just I've enjoyed working with managers and clinicians. I think we have a great bunch of managers, clinicians across the trust. And lastly, although they're not here, and I will say that to them, but I just want to put it a note, I want to thank my finance team. I think they've been amazing support for me. Hopefully I've been a good leader, but that's for them to say. But so all in all, it's been an amazing 3.5 years, and I really do wish Epsom St Helier and the St George's Group all the best. I hope we can get the set built for our patients and for our staff, and I'm sure we will. So thank you very much.
Thank you, Rakesh. And most certainly, I think we all have this shared drive to make sure that the SETCH is there for, as you say, our patients and staff. So Meg, you probably hate me for doing it as well, but I would like to give you an opportunity to say something.
Thank you. Just to say, I've been here 6.5 years and I've enjoyed 99% of it. So just say thank you to Peter as my line manager, but also thank you to the IG corporate governance and EA team that have provided such able, willing and enthusiastic support. So thank you.
Thank you, Meg. And finally, Claire, I'm definitely putting you in a different category because you're just going on secondment. Are you there?
I'm here, and it is certainly a see you later rather than a goodbye, but thank you very much for your kind words. It has been an absolute privilege and an honour to be part of Team Epsom St Helier and to support these executives and non-executives around this table, as well as the wider team out on the front line and beyond. it has been 12 years since I joined as a young 25-year-old. So I've learned a lot, and I'm just incredibly grateful for the opportunities and the challenges that I've experienced at Epsom St Helier. So thank you.
Thank you, Claire. So you can see lots of clapping on the part of all of us for our three colleagues whom we will very much miss. And so I hope there's any other business. Nobody has told me, so I'm assuming not. So that means that we note the date of our next meeting, which is the 14th of January. Martin will actually be in the chair because all other things being equal, I'll be in a hot, sunny place. But I won't tempt fate by telling you where it is. And so that brings the formal meeting to a close. We do have two questions from Miss Lohan. I'm so sorry, Lohendran. I do hope I've pronounced your name properly, and my apologies if I've got that wrong. And the first question is going to be answered, I think, by Ruth. Am I right, Ruth?
Yes, very happy to. Thank you very much. So the question relates to requesting some information on COVID around how many patients have been admitted, how many patients are anti-vaxxers, how many are in intensive care, and then a question about staff vaccination. So we touched on this earlier on, but as of the 10th of November, the Trust was caring for 48 patients with confirmed COVID-19, with 5 patients in critical care with a diagnosis of COVID. That accounted for 7.4% of our inpatient capacity. Since the pandemic began, 2,561 patients who had confirmed COVID have been discharged home. Sadly, 998 patients with COVID-19 have very sadly died. Data from all South West London acute hospitals in October of this year showed that of patients admitted to hospital with COVID-19, 53% of those on general wards and 76% of those in the critical care bed were unvaccinated. In terms of staff vaccination, 83% of staff have been vaccinated. Thank you.
Thank you very much indeed, Ruth. And the second question is about the section, is for you, Trevor.
Thank you, Chairman. So the first question was around, has planning permission been approved for the Special Emergency Care Hospital in Sutton? And I can confirm that no, we have not yet submitted our planning application to London Borough Sutton. We're working on our designs and the technical work for the new hospital, along with engaging with local key stakeholders and residents. The work needs concluding prior to a planning application. The next part of the question was about when will work begin, and we can confirm that planning is well underway, and our target start construction on site is autumn 2022, but that is subject to planning permission approval. And the last question was, what's the latest cost to date? And I can confirm that the 500 million previously agreed by the government remains in place, and this represents the biggest investment in healthcare in the region for a generation, and will ensure that our services can care for local people for many years to come. The Trust is working through the impact of some additional costs, such as future-proofing the new hospital against the future pandemic, ensuring that we meet green environmental standards, and we're also working on our plans to improve the way we can manage patient information digitally. Thank you.
Thank you very much indeed, Trevor, and thank you for those questions. The members of the board have a trust meeting board in private now, which is meant to start in about 3 minutes, but I think we probably need a few more minutes to stretch our legs and get a cup of coffee or whatever. So instead of starting at 11:45, I suggest we start at 11:50. And so thank you very much indeed, everybody, for your contributions and for the public who've attended our meeting, and for executive and non-executive colleagues. See you in 8 minutes' time. Thank you very much indeed. Bye-bye.